Okay, now we can go.
Hello everyone, and good afternoon to each of you present with us today.
Do you want me to start?
This is L. Shalini, representing Rhine Publishers, and I'm glad to welcome you all to the two-day international webinar series on the topic, the Enigma of Dental Health. I would now like to request the participants to make this session more interactive by posting your comments in the Google Meet chat box, and the comments would be read out and simultaneously answered by our resource person. Let me just inform you that the feedback form will be posted on the 24th of October 2020. Joining with us today is our dynamic and valuable resource person, Dr. Shwetha Joshi from Sheffield, UK. Welcome, ma'am. Dr. Shwetha has qualified as a dentist, completing her BDS studies from MS Ramaya Dental College, Bengaluru, India. She has worked in community dentistry in India, treating children with special needs like Asperger's and Down syndrome, and in charities involving elderly care patients with dementia. After completing her internship, she has been working at MS Ramaya Dental Hospital for some time. She has also tried her hands at a private dental clinic in Bengaluru, India. Currently, Dr. Shwetha is working at Sheffield Teaching Hospital's NHS Trust located in the UK. Her main areas of interest revolve around general dentistry, and her specific areas of interest include oral and maxillofacial surgery, Botox and dermal fillers, and facial aesthetics. Dr. Shwetha Joshi is the proud recipient of the Rajiv Gandhi Award for working at Community Dental Health in the year 2009, and an award by Alzheimer's Society in Bangalore the year 2010. In today's session, Dr. Shwetha is going to highlight major points on oral cancer, such as cancer screening, effects of tobacco on oral cancer and management. Now, without further ado, I would request our resource person to please take over the session. Over to ma'am.
Thank you. Thank you, guys. Hello, all of you. Good afternoon, good evening. It's still good morning in the UK. So I would like a bit more interaction from you guys. Just let me know if you can hear me properly. Can you guys hear me?
Yes, ma'am, you're audible. And you can just switch on your video if you would like.
Okay, bear with me. Oh, I have to go to the other screen now.
Dr. Shwetha, we cannot hear you, ma'am.
Can you see me now?
No, that's fine, ma'am. It's fine.
Can you hear me?
Start session.
Yeah, we can hear you.
Okay. Okay. Hi, guys. I'm here today to talk about oral cancer, the early detection and treatment. I would highlight stuff about tobacco, use of tobacco and alcohol, and also the cancer screening we do. So I'd like you guys to be a bit more interactive, and you could ask me questions in between. And if you want to stop me, just let me know, and then I can answer your questions. So let's start. What is mouth cancer? It's the term which covers array tumours arising from a variety of different tissues, but 80% they are squamous cell carcinomas, which arise from the epithelium. To understand squamous cell carcinomas, we need to understand the anatomy and pathology of the epithelial layers. Like the skin has different layers, that's how our oral cavities got different layers. So the most common cancer which usually occurs is squamous cell carcinomas. Now moving on to the next slide. Factors that increase the risk. If it says gender, men twice as likely, but this has changed in recent years. I mean, now more younger females are more likely to get oral cancer. But that doesn't exclude that men can't have it. But then there's still, I mean, it's anybody can get it. The use of tobacco in any of its forms greatly increases the risk. Regularly alcohol, if you take alcohol with tobacco, especially spirits, that increases the risk as well. And infection with certain strains of human papillomavirus also causes oral cancer. And deprivation is something which is like with people with lower socioeconomic background, where people cannot afford regular treatments and they don't look after themselves and they have poor diet, there's lack of vitamins, which is A, C, and E, which is very important. So these are all the risk factors which increase the risk of cancer. Also, there's a lack of selenium and zinc. But then if you've got mouth cancer in the past, that doesn't rule out that you may not get cancer in future. So that is also a factor which increases the risk. Moving on to the next one. Every year, nearly all major cancer types seems to fall in incidence, all of the cancers. But, however, there's a notable exception in incidence of mouth cancer, which is increasing every year. There may be several reasons as to why this is happening, but whatever these reasons may be, but the trend is really worrying. New patterns are emerging. Mouth cancer was once widely considered as a disease of old men, but disturbingly, the greatest increase is now among the young and among women, which I mentioned earlier. Now I'll move on to the next slide. Effects of tobacco on oral health. Smoking is never good. So smoking causes discoloration of the teeth, as we all know. Some argue that tobacco, in fact, might increase dental decay as it lowers the salivary pH and the buffering power. So when the buffering power is reduced, this is when your healthy gums turn into diseased gums. So that's when you'll get a condition called gum disease, which ends up in periodontitis. Smoking is likely to cause halitosis. Halitosis means bad smell, and may affect the smell and taste, like smokers can't smell and taste usually. Smokers may present with generalized melanosis of the oral mucosa. Melanosis is like pigmentation, like melanin pigment. And tobacco smoking, that is cigarette, pipe, or cigar smoking, particularly when combined with heavy alcohol consumption, has been identified as a primary risk factor for approximately 80% of oral malignancies. The risk of oral and pharyngeal cancers is similar for cigarette and cigar smokers, with an overall risk 7 to 10 times higher than for never smokers. It's not very surprising, as the oral cavity is exposed to the carcinogens in smoke, whether the smoke's inhaled or not. like the passive smokers, are more affected than the active smokers. So when the frequency of daily tobacco use is computed, there's a strong dose-response relationship between smoke rates and risk of cancer. Addition of smoking tobacco to the areca quid, like the betel nut, which is very widely used in India, Bangladesh, etc., it raises the relative risk of the product by nearly 15 times. Smoking patients show reduction of inflammatory clinical signs that might be associated with local vasoconstriction from nicotine, but there's not enough blood supply. Guys, usually mouth has a very good blood supply, so if at all you have a cut inside the mouth, you heal very well because the blood supply is excellent. But then in smokers, this always gets reduced. So as it says, there's influence on vasculature and cellular metabolism. Up until now, guys, are you alright with it? Am I going okay? Can you hear me?
Yes, you're going good, ma'am.
Guys, can you hear me? Yeah? Okay. Now moving on to the effect. It's like mouth cancer has devastating effect on sufferers and the people around them, because both the sufferers and the loved ones will be aware of the poor long-term survival rates associated with the disease, which leads to anxiety and worry. Strong sense of unfairness felt by both the patient and those dear to them. It usually causes like sudden behavioral change and reducing the quality of life, and the patients get depressed. It's like, no wonder, because they'll be thinking, why me? So moving on to the next one. It's like mouth cancer does not discriminate. Anyone can be affected. That is why it's so important when looking at the statistics to see beyond the numbers. A little training, a little practice, and taking the trouble to regularly carry out a simple short examination empowers dental professionals like us to be instrumental in saving lives and quality of lives for sufferers and those around them. So guys, please do visit dentist. As we say, in the UK it's usually every 6 months, but please do visit at least once a year. Oral cancer screening usually saves a lot of lives. If you detect cancer early, patient can be saved. This is really important. But most of the patients come at the later stages where it's like beyond, you can't do much. These are the 8 steps we usually use in cancer screening, especially the dentist when you go in for examination. This is done during the examination, where in figure A, call it as gingiva, and then this thing, what's it called, then there's mucosa. And then we check them so there's no bumps and lumps. So we'll have to raise it up like a flap and just check if there's anything underneath, if there's any unhealing ulcer or tumor or anything like that. That's the first figure. The second one you'll have to check the lips, upper lips. And then in the third figure, we do the tongue. We do the buccal mucosa, not the tongue. It's the back side of your teeth. We call it as posterior gingiva. And then in the fourth figure, we check the vestibule, and then we check the anterior gingiva, and then it's the mucosa again. And then in the fifth one, we check the hard palate, because there may be lumps and bumps in hard palate. And then the next one, we check the soft palate, which is behind. As you can see, these two blue dots, those are the tonsillar areas there. The soft palate is here and the tonsillar area is here. That's where we check. And then we have a ventral surface of the tongue. That's where we check. And then what we do, we do check the lateral borders of the tongue. That's the side of the tongue. Because sometimes cancer does present on the side of the tongue. So that's oral cancer screening, which has to be done by the dentist. I mean, all the dentists have to do it, regardless. So I'll move on to the next one. Survival rates in detail. Survival rates depend on these three factors. It's called TNM factor, where T is called represents the size of discrete tumor. So the smaller the size, earlier you detect, you can do something about it. But then the larger the tumor, that means it's spreading. So, and then N represents the lymph nodes, whether they've been infiltrated or not. And M represents the presence or absence of metastasis. That's multiplying. The cancerous cells multiply. That's called metastasis. So the TNM factor is very important for us to determine the survival rates in patients. From these three criteria, as I said, the stage of the disease can be determined. So, for example, a tumor which is less than 2 centimeters in diameter with no evidence of spread to lymph nodes or remote organs is termed stage 1. Then the tumor at this stage will often be visible to the naked eye, but sadly, only 4% of lesions are detected this early. If detected, the patient may expect a chance of 5-year survival up to 94%. Most cases are discovered at much later stages, as I mentioned earlier. At stage 2, the survival rate will have dropped to about 65%, where 68% of cancers are identified at stage 3 and 4, when lymph gland involvement and metastasis may be present. Patients diagnosed at stage 3 have no better than 27% chance of 5-year survival, while only 5% of patients diagnosed at stage 4 will be alive after this time period. This is really sad. This is one of the studies I took because it's very interesting. In in a study in the USA, virtually all dental practitioners claim to conduct regular oral cancer screenings in a country like US, but only 15% of patients actually reported receiving a mouth cancer examination, with the truth probably somewhere in between. So it's really sad. Not all clinicians routinely examine. Many more fail to tell their patients what they're doing or why. It is vital that dental teams inform their patients about procedures being carried out. Without information, patients have no way of knowing which procedures have been provided. So, here we go. Incidences. In UK, the oral cancer accounts for nearly twice the mortality morbidity rate of cervical cancer. So basically, twice the cervical cancer. But then there's cervical cancer screening every year, which is conducted here. And then yet, it attracts a fraction of attention, because people just don't pay attention. And then Cancer Research UK in 2005, this is a study they did, which they say that 4,926 oral cancers versus in 2005, 2,803 cervical cancer. So basically, cervical cancer is decreasing. So every year, most of the cancers decrease, but then it's only the oral cancer which is increasing. More lives in the UK are lost through mouth cancer than through road traffic accidents. That's very sad. Moving on to my next slide. Guys, I've just shared this picture because you see in this picture, this looks like ulcer, but this is a cancer because this is detected in early stage. Because if this ulcer, more than 3 weeks, if it's not healed, as I said earlier, whatever happens in mouth, if there's a slightest cut, it heals really well. And this thing, if it doesn't heal, if there's something which looks like this and doesn't heal within 3 weeks, that means it is a cancerous lesion. So that has to be immediately sent out to the specialist and do all the examinations and everything. So mouth cancer can occur anywhere in the mouth. As I told you earlier, the lateral borders of the tongue, the sides of the tongue, that is a cancerous lesion. And then on the roof of the mouth, that's where it is. 3 signs of oral cancer. This was given by American Dental Association. A sore, same you have a sore, maybe a lip sore or the sore inside your mouth which doesn't go away, after say 3 weeks, then it's serious. Then probably you may see red or white patches sometimes. I'm not saying all of you, but this thing, what's it called? This is most common usually in patients with tobacco use, and then the ones with areca nut, betel nut, and who drink a lot of alcohol and spirits. Then there's usually persistent pain or tenderness when swallowing. That's when you know there's something wrong with the throat. Probably there's a throat cancer. In the next slide, I'm just sharing these common symptoms of oral cancer. This is just really like an overview. I mean, I've not put a lot of details into it. I don't want to go into technicalities, but this is the most common symptoms you'll find. It's red and white patches inside the mouth, ulcers or sores that do not heal within 14 days, a lump in the neck. Usually it's in this area, because the dentist, when they do examination, they do under the chin as well, because just to check the lumps. And then there's pain or bleeding in the mouth, usually. I mean, unexplained why pain or bleeding in the mouth. And then difficulty in swallowing. This is where something's wrong with the throat. Persistent pain in the throat. Oh yeah, guys, it's all connected. So that's again serious alarm. It's raising an alarm bell. And then serious speech problems. Then there's something's wrong. Usually when we find something like that, the first thing, these are like the diagnostic aids we usually use, like biopsy. Usually a small sample of affected tissue will need to be removed and checked for cancerous cells. This procedure is called biopsy. The main methods usually used to do a biopsy in cases of suspected mouth cancer are an incision or punch biopsy. Probably cut a part of cancerous tissue, send it for an examination, more for microbiology. And then you have a fine needle aspiration with cytology. This is when you've got a tissue filled with a fluid, you just use the syringe to aspirate a bit, and then you send that, and you brush the top bit of the tissue so you can get some cells, and that's when that's being sent for examination, further examination. Nasendoscopy is like a nasendoscope is like a thin tube which has got a camera at its end. So that's usually inserted into the nostrils, and it goes back. This is very useful in throat cancer usually. And then it folds backward, and then it records the picture, and then it's safe. Obviously it shows the size of the tumor. Then panendoscope is slightly bigger than nasendoscope. When the tumors are slightly bigger, that's what's used. So basically similar terminologies, but this is a bit bigger tube compared to nasendoscope. And then the treatment. Oral cancer treatment. Treating oral cancers usually involves professionals from a variety of disciplines. It's just not dentists. It's surgeons, radiation and chemotherapy oncologists. Then you've got dentists, you've got nutritionists, because they can't eat very well and they've got vitamin deficiencies. And if there's a throat cancer, then the whole of the nutrition, whatever they're taking, it has to be molded accordingly. And then the rehabilitation specialists, because they'll be very depressed, so you do need them. There are several oral cancer treatment options. The first one, usually surgery, is the most common form. The extent of any surgery will be dependent on the stage of the oral cancer. If the cancer has spread, the surgery will be more extensive. May involve the removal of some of the lymph nodes in the neck. So surgery is like when it's big. And then radiotherapy is used after surgery to eliminate any remaining cancer cells. So basically after the surgery, if there's any remaining cancer cells, that's you've destroyed by radiotherapy. It's also often used to treat oral cancers that have not spread to the other parts of the body. Then you've got chemotherapy. Chemotherapy can be used in combination with radiotherapy to treat oral cancers that have spread to the other parts of the body, or to treat oral cancers that have reappeared after earlier treatment. So, chemotherapy, as you guys all know, plays a big role. This is a new one, monoclonal antibody therapy. I mean, it's not pretty new, but this thing, what's it called? It's usually used as a targeted therapy. The therapy only targets the cancerous cells, not the good cells, it's just the cancerous cells. It's usually used in conjunction with radiotherapy or chemotherapy. It involves the use of monoclonal antibodies, which are genetically engineered to target and attack cancer cells. The specific type of monoclonal antibody which is usually used in the treatment of oral cancer is called cetuximab. So this is the one we use. So that's my last slide, guys. You've got to wake up, fight cancer, be kind, undergoing cancer. If you know somebody, just help them, or you yourself, if you want to if you want to take precautions, just go to dentist, just get your teeth checked regularly. That's what I would say. So that's my last slide. Is there any questions for me?
Thank you so much, ma'am. The session is now open for interaction, so participants can post their questions in the comment box.
Is there any question, guys? No questions?
Participants are requested to post their questions, if any. Or if not, we can just wind up with the session.
Okay, yeah. Thank you very much, guys. Really got some good comments. And hopefully you liked it, because hopefully I wasn't too fast.
So can we just wind up the session now? And on behalf of Brian Publishing,
Yeah. If you yeah.
On behalf of Rand Publishers, I take this opportunity to thank our resource person for the time and effort taken to prepare the presentation and for conveying her best acquired knowledge on the topics related to oral cancer, the signs and incidences of oral cancer as well, and hope our participants found this session useful. And I would like to thank you all for making this session a successful one. If you find our webinar event useful, kindly share a word with your friends and please do participate in our future events as well. Don't forget to subscribe to our YouTube channel, and for the feedback form, it will be posted on the 24th of October 2020. Thank you so much, Dr. Shwetha, once again for joining us today. And signing off for now.
Thank you very much.
Signing off for now, this is El Shah.
Thank you very much, guys.
Wishing you all a happy weekend.
Bye, guys. Thank you very much.
Bye.
Thank you. Bye.